So, welcome to Healing Endo Beyond Symptoms to a Root Cause Approach. My name is Nicole, and I'll be going through this presentation with you today. First off, this is just a general disclaimer that this content is not a substitute for medical advice, and to always, seek out your doctor or another qualified health provider if you have any questions regarding a medical condition. And a little bit about me. As I said, my name is Nicole and I run learnbodyliteracy.com. I'm a menstrual health educator who began charting my fertility back in 2015. And I went public with my charting about a year after I had started because I felt like it was a really important topic that not many people were discussing publicly. So that's kind of what motivated me to start charting publicly. And I started with a hashtag, which eventually became Learn Body Literacy through development and time. And I'm an artist, so my background is in art, and I started making work about menstruation as well. And visuals are a big part of my practice. I created the Body Literacy Visual Reader and Coloring Book, and I believe that seeing ourselves is an important part of this whole process of body literacy and learning about ourselves. So I also write and blog, I make guidebooks, and I teach classes about the menstrual cycle and fertility awareness. In addition to this, I also run a small apothecary with my partner called Polycultured, and we have a focus on preventative health, especially since the pandemic, and also reproductive and sexual health. So that's sort of my concentration and my background, a little bit about me. And now we'll get into the content of the presentation. And the reason why I'm having this webinar is because I just released an 8-module course called Endometriosis Essentials. And it goes through what you'll see in this presentation, but an even deeper dive into the condition. And like I said, it has 8 different videos within it. This is what they are about. They each cover a different topic related to the condition. And they're also a holistic way of looking at endometriosis, really weighing out all of the different medical options, what we know about endometriosis through research, and also what we have yet to learn. So if you enjoy this presentation and you either have endometriosis or are working with someone who has endo, it may be useful to you to do a deeper dive. So I hope you enjoy that. And so we'll just get started with the basics of, what is endometriosis? It's a disease that's characterized by the presence of pain and or endometriosis lesions. And these lesions may be located on the reproductive organs as well as many other body structures. And there's currently no medical cure for endometriosis. It can be a lifelong, debilitating, and chronic condition. And the best standard of treatment at this time is considered to be excision surgery, which is performed by an endometriosis specialist. They're typically called an excision surgeon. And endometriosis, as I said, it commonly occurs on the reproductive or pelvic structures, causing severe pain, bowel, bladder, or other pelvic organ dysfunction, inflammation, scarring, adhesions, various kinds of organ dysfunction and immunologic abnormalities. Other endocrine alterations come from that, and infertility. And although it's commonly thought of as a pelvic disease and it's mainly treated by a gynecologist as the first doctor that the person's going to encounter, more research is continuing to amount about the extra pelvic forms of endometriosis. So endometriosis that's found not anywhere near the pelvic structures. And we'll talk a little bit more about that. So in my course, Endometriosis Essentials, I consider endo to be a full body disease. It's a systemic inflammatory disease that can affect the whole body. It's comprised of these hormone responsive lesions, which can produce their own estrogen. And once thought of as a female-only disease, endometriosis has also been located in persons with the male phenotype at the bladder, near the spermatic cord, epididymis, vas deferens, testes, prostate, and places on their abdominal wall. And endometriosis lesions are not normal endometrium that's found in the uterus. So we'll talk about that in greater detail as well. Here's just an overview of some of the areas where endometriosis has been found. Um, the most common places are around the ovaries, the uterus, the bowels, the bladder, but it's also been found in other places such as the chest cavity, lungs, diaphragm, liver, stomach, brain and brainstem, the pelvic and sciatic nerves. And the question is, are lesions and adhesions the cause of the pain? So we're commonly taught that the lesions and adhesions in endometriosis are what's causing the pain with endometriosis, and that's why the treatment is to remove them. But in real practice, we actually find that there's many different presentations of endometriosis, many different scenarios of people who fall under this umbrella. So some people have the lesions confirmed with laparoscopy, like looking in with a camera, but they have no pain. So they find out incidentally, maybe for another reason, that there's some endometriosis present. Other people have the lesions present and they have pain. And then there's another scenario where people have no lesions present, at least ones that aren't identified or can't be seen, but they do have unexplained pain. So this makes the disease very difficult to pinpoint, you can imagine. All presentations that we see here are, of course, valid and deserve full healthcare investigations into their causes and the best treatments. And further complicating endometriosis, and honestly why it took so long for me to create this course, is because it's very heterogeneous. There's a lot of different aspects to this condition. And a lot of different aspects have been studied, which is also a good thing, that we're able to kind of construct all these different elements and bring them into the larger architecture of what's going on with the condition. So this is just a visual to get you to understand that there is not just one particular cause. There's a lot of different things going on. And conversely, you can use this knowledge to pinpoint different parts of your treatment. So we'll be talking about a lot of these different aspects today. And another introductory point that I want to make sure that we drive home is that endometriosis is not the uterine lining. It's a disease characterized by the presence of these endometriosis lesions that can occur on different body structures, but the lesions themselves, they are different in structure and behave differently from normal uterine lining. This is not just uterine lining that got placed somewhere else. Endometrium, in other words, the lining of the uterus, that's histologically different, meaning when we look at it under the microscope, it doesn't do the same thing that the uterine lining does. The only similarities here are that they have the functional glands and stroma that the uterine lining has. So we'll talk about that in greater detail. What is the difference, between the uterine lining and endometriosis lesions? Because they are not the same thing. And also throughout the presentation, you may see these PMID numbers, and you can look into them later. They usually reference something that's on the slide. So let's start out with the causes of endometriosis, what we know. So the first theory and the oldest theory is called the Sampson's theory of retrograde menstruation, and you've probably heard about it because this is the one that's still most widely disseminated, despite us knowing that it is not the same as regular uterine lining. So it says that the cause of endometriosis is the result of a backflow of endometrium into the peritoneum, which is just your membrane lining of your abdomen. And so it's saying that basically this backflowed endometrium gets implanted in different places. And we know now that endometriosis is not comprised of actual endometrial cells that are backflowed and behaving abnormally. Endometriosis lesions are fundamentally different structures. And despite there having been quite a few studies now to disprove this old theory. It's unfortunately still very much referred to when explaining endo, sometimes from doctors explaining it. It really confuses the public's understanding of what this disease is. And so it's essential that we understand the various factors that actually contribute to the disease and all this misinformation that ends up leading to failed concepts of treatment. So that's obviously the big downside of us continuing with this debunked theory, is that you have then treatments that are informed by the theory, such as hysterectomy, drug therapy, and incomplete surgery, like ablation surgery. So we'll talk about that a little bit later as well. So another more promising theory about where endo comes from is a form of immunologic dysfunction. And that change in the immune system allows endometriosis lesions to take hold in the body. And though immune dysfunction may play a role in lesion development, it's not considered an autoimmune disease. It may be linked to several autoimmune disorders, which I have another slide for, and it may share some underlying pathophysiology, but it's also has some differences from your typical autoimmune conditions. There's also this thing called apoptosis suppression in endometriosis. This is the inability of the immune system to destroy foreign or enemy cells, which can, contributes to its proliferation. And endo produces inflammatory cytokines and other immune factors that inflame and promote the growth of the lesions. So it shares many features with other immune diseases. And one of those we'll talk about also is angiogenesis, or the ability of the lesions to establish their own blood supply. So we see that with other immune conditions as well. And there are two major parts of your immune system, the innate immune system and the adaptive. And your innate immunity is that rapid, nonspecific response that's present from when you're born, whereas adaptive immunity is a more slow, antigen-specific immunity that develops over time, the memory that your immune system has. So the innate immune system should be what's taking care of the endometriosis lesions, not allowing them to even take hold, but for some reason it's not doing its job correctly. And it's been found that endo sufferers have a lower natural killer cell activity in their abdominal fluid and reduced phagocytosis by macrophages, even though the macrophages are present. So what this means is that the immune system should know that those lesions are there and start to clean them up immediately, not allowing them to actually form, but they don't for some reason with endometriosis, and instead they're able to establish a blood supply, establish a nerve supply. And so this has to do with some alterations to the immune environment. The adaptive immune system in endo sufferers is also abnormal. So there's also other things going on here with more B cells, T cells, and antibodies present. So overall, the person with endometriosis compared to a control person is a different immune environment. And this is a big part of what we're going to consider in Endometriosis Essentials as to how to treat the condition. The next cause of endo I wanted to talk about was the relation to gut disease and microbial dysbiosis. So most of your immune function is located in your gut, and endometriosis seems to have a lot of close correlations with bowel disease. Not only can the lesions grow directly on the bowels themselves, but there's also studies that have looked at intestinal permeability that leads to the bacteria from the gut leaking out into the surrounding area, to the pelvis and the reproductive organs. And these bacteria produce a lipopolysaccharide toxin that's found in the menstrual blood of those with endo, which promotes endometriosis and just an inflammatory state in the pelvic region in general. The next studied cause of endo is what's going on with the genetic factors. So another theory cites genetic factors. There appears to be a 7 to 10-fold risk of endometriosis in those who have a mother or a relative with the disease. And there's a dysfunction in various genes related to endo, and I actually have some slides for this further forward so we can talk about that in greater detail. And endo has also been found in fetuses, which again suggests that there may be an embryologic origin. And that was popularized by Dr. David B. Redwine. And during embryonic development, basically your Müllerian ducts form parts of your reproductive tract. And if small bits of that tissue are left behind or migrate abnormally during your fetal development, they can later become active under various hormonal influences, creating the lesions. So this is one theory as to why we see endometriosis in people who haven't menstruated yet. And in rare cases, even in fetuses and infants. And it's also may explain why it's found in more unusual locations than just surrounding the uterine tubes, where that backflow theory would say that it would mostly deposit. Another cause of endo may be environmental exposures. There are many theories related to certain toxins, which can cause cell changes related to the immune response. And in particular, dioxins and diethylstilbestrol, when exposed in the womb specifically, may cause the risk of endometriosis to increase. And dioxins are already known as endocrine disruptors. They interfere with a whole bunch of different hormone signaling and different pathways. So it's no surprise that it may be a factor here. There's also the discovery that stem cells, such as endometrial stem cells and bone marrow-derived stem cells, can migrate. And when they do that, they're able to potentially form endometriosis-like tissue outside the uterus. And stem cells are very unique because they can become many types of tissue. They're highly mobile. That's why there's an interest in them being used in scientific research. But researchers found here that stem cells could seed lesions even when there is no menstruation involved. So this is yet another theory related to the, I'm sorry, I see a comment here, 1 second. What would be some things that introduce those toxins, food, cosmetics, air, etc.? Yeah, I believe dioxins are through mostly through cosmetics, not through food, but we can double check on that. I believe they're more of like related to personal care products and plastics and things. So stem cells have been linked to endometriosis because they've demonstrated that ability to populate the lesions even when there's no menstruation present. So this is yet another theory related to the development of the cause of endometriosis. And of course, as you can see here, there are many theories. There's no single set of criteria which can account for the millions of people that have endometriosis, and it's most likely that people are born with certain mechanisms which can trigger the disease some later point in life. And this is probably the result of interplay between genetic and environmental factors. But what we know here is that it's not a lifestyle disease, it's not a hormonal disease, and it's not a psychological disorder, of course, even though in the past, all three of those things have been proposed dubiously. And many people are surprised to learn that endo is not a hormonal disease because it's often associated with estrogen, but estrogen does not cause endometriosis. So it's not the case of someone having too much estrogen, and even normal amounts of estrogen can stimulate endolesion growth. It's that endolesions produce their own estrogen, independent of the menstrual cycle, meaning the absence of a cycle does not cure endometriosis. On the other hand, progesterone seems to have a positive effect on endolesions. It slows their growth. However, lesions are actually progesterone resistant. So we'll talk about that in just a moment. For both of these reasons, there are numerous problems with the hormonal therapies that have been developed for endo. They're ineffective at treating or reversing endometriosis because these lesions, they react differently and are sometimes hormonally resistant, and therefore hormonal therapies are not that effective. People have varying experiences with hormonal therapies for symptom relief, of course, which needs to be considered. Okay, I hope everyone's with me so far and enjoying this. We're going to move on to talking about symptoms of endometriosis. I'm just going to take a quick sip of water. The centralizing symptom to endometriosis is pain. Endometriosis patients are more likely to report throbbing pain along with a bunch of other unique symptoms. Here is just a quick list of them. Pelvic pain that gets worse after sex or pelvic exam, abdominal pelvic pain apart from menses, so just at any point in the cycle, chronically heavy or long periods, bowel and urinary disorders often associated with periods, painful sexual activity, significant or debilitating lower back pain, allergies, migraines, fatigue, a lot of stuff that tends to happen around menses as well, and menstrual pain, of course. Pelvic endometriosis is traditionally defined as lesions on the uterine tubes, the ovaries, and the local peritoneum, which again is your abdominal cavity. And now it also includes the gastrointestinal tract and urinary tract. Whereas extrapelvic endometriosis is much more wide-ranging. It refers to lesions that are found on the pulmonary system, on your extremities, your skin, your nervous system, and areas of the brain. There are rare manifestations of the disease found in a bunch of different places, so we'll talk about that. But the classic pelvic symptoms, again, are going to be related to painful pelvis or things going on in the gastrointestinal tract, constipation, rectal bleeding, bowel or bladder pain. Chronic fatigue and infertility is also related to this. Some people report sharp knife-like pains. Other people report bladder symptoms or issues with their digestion, especially if those organs are impacted. Whereas with extrapelvic endometriosis, for instance, endometriosis in the lungs or the chest, you'll have things like coughing up blood, tightness of breath, pain in your chest, even lung collapse and air leaking into the chest cavity is possible with this form of endometriosis. In sciatic endometriosis, you have leg and lower back pain, headaches, burning and other types of sensations going on when it's actually affecting the nerve. So these are just some examples of, if you present with these, the average gynecologist is not going to necessarily be able to identify that this is lung endo, for example. So there's also psychological and social impacts here due to the stigma, the dismissal, the underdiagnosis. Obviously, many medical professionals are not even defining the disease correctly. So there's a significant impact to this with living with this condition. And depression and other mood conditions are common, has obviously a profound impact on people's lives. And each person has this really unique mix of symptoms, and it can't really just be looked at through a reproductive disease that only affects the reproductive organs or a hormonal disease only affecting the endocrine system. So it's much more likely that with every case of endometriosis, the person is going to have multiple body systems involved. And that's something that really needs to be much more in the forefront when it comes to treating this disease. So next here, we'll talk about the lesion structure. What are we actually talking about with endometriosis lesions, and what's the difference between them and the endometrium? So the lesions are multicellular tissue deposits. They contain endometrioid glandular structures made up of epithelial cells and stromal cells. That's what's similar to the utopic endometrium. And the lesions become vascularized. They become innervated and infiltrated by immune cells like macrophages, mast cells, and natural killer cells. And an isolation of specific cell types from the lesions is quite difficult due to the limited tissue available in biopsies And in most cases, the exploration of cellular interactions is recreated using cell models, and disease-specific effects on physiology are modeled in vivo. So this is really interesting as well because it explains, part of why it's difficult to study endometriosis. So the connection here between endometrium and endometriosis is that the uterine lining consists of epithelial and stromal cells. The epithelial cells normally form the surface epithelium and the lining of the uterine gland, whereas the stromal cells make up the connective tissue that supports these structures. So if we're looking here on this graphic, you can see that the epithelial cells are on the surface and the stromal cells are below them. So with endostructure, how is this different? So while endometriotic lesions structurally resemble the uterine lining, where they also have epithelial and stromal cells, they're functionally different and dysfunctional. So the epithelial cells in endometriosis form gland-like structures, and they act like the surface lining of the gland and are involved in the secretion and the barrier functions, whereas the stromal cells are supporting the cells around those glands, and they provide the structure, regulate the local environment, and interact closely with the immune and blood vessel cells. And they're somewhat hormonally responsive and a key to how the lesion grows and behaves. So what you're seeing here in this graphic is the initial endometriosis lesion seeding, and then it creating this very strong epithelial top, and then underneath the stromal cells, as well as it's showing you all these other immune cells that are present. So endometriotic tissue may look like endometrium. It has the same basic cell types, but it's biochemically, hormonally, and immunologically abnormal. It's basically a pathological mimicry, not a true copy of the uterine lining. So we can't actually say where it is derived. And estrogen also plays a crucial role in the development and the growth of endometriosis. So the enzyme that is responsible for producing estrogen is called aromatase. And interestingly, there is no aromatase in healthy uterine lining. Remember that in the menstrual cycle, healthy amounts of estrogen are made, but they're made in your ovaries. That's what generates your hormones, not your uterine lining. Your uterine lining responds to the messages from the ovarian estrogen. And with endometriosis lesions, instead, inside of the lesion, there's extremely high levels of aromatase, and aromatase makes estrogen. And so that's what leads to a surge in estrogen production, is the lesions actually having this aromatase present. And estrogen boosts the production of prostaglandin E2, which creates a self-sustaining cycle that exacerbates symptoms, because prostaglandin E2, sometimes that's abbreviated PGE2, is a key signifier in inflammation and pain. So because endo has this unique ability to make its own estrogen, and it's a potent form of estrogen called estradiol, it does this by using cholesterol and other hormonal building blocks. And another thing that's really different and interesting about these lesions is that they're resistant to estrogen's regulatory measures, meaning when you have a menstrual cycle, your estrogen goes through a period where it's high and then a period where it's low. And that regulates your menstrual cycle, as does progesterone and other hormones. And what's happening with these lesions is that the receptors for estrogen in them are also altered. So in the normal endometrium in the uterus, you have a lot of estrogen receptor alpha. And instead with the lesions, we have an increase in estrogen receptor beta. And so this is, again, what changes how these lesions respond to estrogen because of these different receptors. So just to recap for you, endolesions produce their own estrogen, and they do that through an enzyme called aromatase. They're resistant to the normal estrogen regulatory measures of your menstrual cycle, And estrogen boosts the production of prostaglandin E2, and that's part of what creates an inflammatory state, exacerbating the pain symptoms. So as I said, prostaglandin E2, it's a lipid molecule. It's part of a bigger family called prostaglandins, which you may have heard of as it's related somewhat to menstrual pain. These molecules are made during inflammation, and they control a lot of important things related to pain, swelling, blood flow, fever. But PGE2 is very elevated inside of the endometriosis lesions. It promotes inflammation, and that's why there's pain and swelling in the area. And it also stimulates aromatase activity. So when you have more prostaglandin, you have more aromatase. More aromatase makes more estrogen. You have more lesion growth. So you can just see this process starts to create a feedback loop. Once the lesions have started to take hold, you have this going around as the lesion is developing, and as more lesions are developing, you have more of this process happening. Aromatase, it's an enzyme, it's a protein that helps speed up chemical reactions in the body, and its main job is it takes androgens from the body and converts them into estrogens. So in short, it makes estrogen from other building blocks. Normally, estrogen comes from your ovaries, but with endometriosis, the lesions themselves produce their own estrogen. And that aromatase is highly active in the endometriosis lesions. That's what self-fuels it making its own estrogen, and more estrogen equals more lesion growth and inflammation. So this is part of the reason why just getting rid of the menstrual cycle and stopping making ovarian estrogen is not totally effective for endometriosis, because the lesion itself is like its own little estrogen production center. And this is just showing you the aromatase and how aromatase inhibitors will actually be able to stop aromatase from doing its job. And I think aromatase inhibitors are a really interesting point of treatment for endometriosis for this reason. And just a short bit here about endo and progesterone resistance. Recall that the menstrual cycle operates in balance. There's estrogen in the preovulatory phase and progesterone in the postovulatory phase. And endometriosis lesions lack the ability to respond to progesterone, which is normally estrogen regulating under typical conditions. When progesterone is high, estrogen should be lower. And there's a reduction in progesterone receptors inside of the endometriosis lesion. So even though it seems like people with endo respond positively to progesterone, there's also a bit of resistance in the actual lesion itself. So this is really interesting how both estrogen and progesterone they're abnormal, the receptors in the lesion. And that means that they do receive some of the messages from the menstrual cycle from estrogen and progesterone, but what they do with those messages is, a little bit off from how your uterus would respond. The immunomenstrual axis is another area of research that I have been studying for the past few years, because a lot of the reproductive health conditions that I help people with end up having an immune component. And that's been really interesting to me. Obviously, with the pandemic, you can see that there's lots of connections between the menstrual cycle and what's going on with people's viral infections. So it really became an area of interest for me. And I started to learn more about how endo was related to autoimmune conditions. So it's not officially classified as an autoimmune disease, though should it be? I don't know. It shares a lot of features. So there's chronic inflammation, immune system dysfunction, higher rates of co-occurrence of autoimmune illness, such as lupus, rheumatoid arthritis, Hashimoto's thyroiditis, which is the autoimmune thyroid condition, multiple sclerosis, and inflammatory bowel disease all have higher correlations to endometriosis. And as I said, there's quite a few similarities to autoimmune conditions, such as the immune system dysfunction. the shared genetic and environmental risks, and the immunohormonal axis, where somehow hormones are also impacting the disease. But there are also a few differences, and this is perhaps why it has not been classified this way yet. So, in autoimmune diseases, the immune system is directly attacking part of the body's own tissues. The immune system is attacking the joints in rheumatoid arthritis. That's what's happening. In endometriosis, the immune system is dysregulated. It's allowing these lesions to proliferate, but it's not directly attacking the tissue. It's more like the immune system is failing to clean up tissue rather than aggressively destroying normal body parts. And there's no specific autoantibody that's consistently found with endometriosis. There are lots of antibodies that are able to either generally or specifically look at autoimmune conditions. And some autoantibodies have been detected, but they aren't consistent with endometriosis, meaning that some people, if they were to test negative, would, they would fall out of the criteria of the disease, even though they have it. So you can't just take a blood test and definitively say, yes, you have endometriosis, though they are constantly looking for new markers related to this. And this is probably because the exact cause is still unknown. Autoimmune diseases usually involve a combination of genetic and immune regulation defects, but there's many factors in endometriosis. So this is part of why it hasn't been classed this way yet. And I just wanted to quickly introduce the immunomenstrual axis, which is just a description of the communication and interrelationship between the immune system and the menstrual cycle. The menstrual cycle is actually determined by immune events. Both ovulation and menstruation are immune-mediated events where you need a healthy immune system to come in and do a certain job in order for the egg to be released and also for the uterine lining to be released. And so I just thought this was a really fascinating concept where the immune system is integrally linked to menstruation. And it has, pretty much a role to play in every step of the process, all the way into the tissue repair after the menstruation is finished. And you also have different immune cells present in different phases of your menstrual cycle. And that's what these slides basically go through, explaining the first half of the cycle, where you generally have a predominance of type 1 helper T cells and immunoglobulin A antibodies. Whereas in the second half of the cycle, the luteal phase, you have higher levels of immunoglobulin G, innate lymphoid cells, and type 2 helper T cells. And this switch promotes a different kind of immunity. It has to do with the potential conception that's possible, potential pregnancy that's possible in the second half of the cycle. And one thing that I've noticed over time is that dysregulated cycles that are characterized by a prolonged exposure to estrogen seem to be correlated with a higher disease risk and cancer risk as well. So the menstrual cycle is known to be affected by acute immune events, meaning if you get sick, sometimes your menstrual cycle behaves differently afterwards or during. And its dysregulation is associated with a lot of chronic immune conditions. So when we see reproductive health conditions, we do always need to look at the immune component to treat the person holistically. There's also a big connection between adenomyosis and endometriosis. Adenomyosis is a non-cancerous uterine disorder where there's a presence of the endometriosis, but inside of the muscle layer of the uterus called the myometrium. And there's a large coexistence here. About 50% of people have endometriosis and adenomyosis, but there's no evidence that one condition causes the other, although some people do liken adenomyosis to a type of endometriosis, a form of endometriosis, because of the strong relationship. There's also a lot of uterine fibroids that seem to coexist with adenomyosis. Now, surgical management is much more available for endometriosis. With adenomyosis, it's usually not treated surgically without hysterectomy. And both of these conditions are correlated with changes to the immune system and a dysregulated microbiome. And I think that a lot of the time, in at least in my past work with people with adenomyosis, a very similar protocol to endometriosis is usually indicated because of all of these similarities, especially if you're looking at it from a non-surgical perspective. There's also dendritic cells. These are immune cells. They're kind of like immune cells that go tell other cells, hey, something's going on here. Immune cells are obviously interlinked here with the development of endometriosis. So the dendritic cells are behaving abnormally, where normally they should be telling the rest of the immune system, hey, we need to clean up this issue. Instead, with endometriosis, they promote angiogenesis. So the dendritic cells actually encourage the formation of new blood vessels and endothelial cell migration. That's what helps vascularize the lesion rather than supporting beneficial immune function. And this helps endometriosis lesions grow by building blood supply and failing to regulate the immune response properly. There's also CCL5, which is known as RANTES, which is a chemokine. It's a signaling protein that plays a role in inflammation. And we see much higher levels of CCL5 in an inflamed environment, such as endometriosis. So this is also really interesting immunology, because basically these immune cells are acting abnormally and they're going to the site of the endometriosis lesion. And there's also higher expressions of, again, the estrogen receptor beta rather than the estrogen receptor alpha in the endometriosis lesion, which is related to these different kinds of immune cells that are populating the area. All of this to say that it plays a role in the inflammatory factors that are found in endometriosis. There's also the fact that endometriosis causes hypoxia, or a low oxygen environment, due to inadequate blood supply, especially when the lesions are just forming. And hypoxia triggers an expression of this HIF-1 alpha, which promotes angiogenesis again. And again, this helps support the lesion's survival and growth, and increases various inflammatory cytokines such as IL-6 and TNF alpha, and that also contributes to some of the pain and lesion persistence. So hypoxia in the lesion is another aspect of how the condition takes hold. Then there's another immune component called CD47, and this one really amazed me when I first learned about it. It's kind of called the "don't eat me" signal. It's this protein that prevents macrophages from phagocytosing, which just means that it prevents them from engulfing and destroying the cells, including cancer cells. So lowering CD47 expression is being explored in cancer therapy to enhance immune clearance of tumors. And endometriosis lesions often overexpress CD47, which is really interesting that it has this overlap with cancer, where it allows them to evade immune clearance by inhibiting macrophage phagocytosis, survive an implant in the peritoneal cavity or other ectopic sites, and contribute to chronic inflammation, pain, and lesion persistence. So in short, CD47, or this "don't eat me" signal, helps the lesions hide from the immune system, much like cancerous tumor cells do. So this is super alarming to me and concerning that there's this overlap. And people have also, put out the idea that maybe endometriosis is a form of cancer. Right now it's considered benign, so it's in the benign growths sort of area. However, again, with immunologic dysfunction and things like CD47, we do need to look at, what's the overlaps here, and possibly are there connections that can be made. Next, we'll talk about genetic components. So there's mitochondrial mutations with endometriosis, mitochondrial DNA or mtDNA. Mutations and altered mitochondrial function are linked to endometriosis. There's decreased mitochondrial DNA and increased mutations in affected cells. And certain mitochondrial DNA polymorphisms, like those in the D loop region, have been implicated in endometriosis development and progression. So that just means that endometriosis can affect cellular energy production. And of course, this contributes to the inflammatory processes related to endometriosis development. There's a decreased expression of CDH1 in epithelial cells, and that's found in advanced peritoneal endometriosis. And what that results in is this thing called epithelial to mesenchymal transition, which is the process where there's an increase in metastatic potential of malignant cells. By enabling the endometrial cells to acquire migratory and invasive properties, it allows them to implant and survive in ectopic locations. There's also PTEN, which is a tumor suppressor that may also play a role in endometriosis, as mutations in this gene are implicated in various cancers. So again, you can see that like when you really do look at the research, there's quite a bit of overlap here with what's going on with genes related to the condition. And even though endometriosis is benign, the association with these genes is of course a serious cause for concern. And also, how benign is it? I mean, like, it's progressive and it can destroy people's organs and cause a lot more pain than it needed to if it was diagnosed earlier. In a similar way, where when cancer is found in a later stage, it's harder to treat. There's also been lots of large-scale genetic studies on endometriosis, and they found associations through these larger studies. So there's, of course, a strong association with autoimmune diseases and autoinflammatory conditions as well. And there's a 30 to 80% increased risk of developing other immune conditions when you have endometriosis. So obviously, this is a huge cause for concern because endometriosis is a difficult disease on its own. But when it increases your risk of developing other conditions, it will decrease quality of life and even shorten quality of life, longevity of life, excuse me. So this suggests that there may be, some causal link, especially with rheumatoid arthritis and osteoarthritis, which was really interesting, this research. There's also single RNA sequencing that's found the expression of other genes, and this is just a few. And on the right in the graphic, they list a lot of them off. And as you can see, it's pretty wide-ranging, these genetic relations that have been found. So when it comes down to the roots of endometriosis, the lesions have a unique structure. They behave differently from normal endometrium, and endometriosis is ultimately multifactorial. There's a severely disrupted immune environment, the ability to create its own estrogen independent of the menstrual cycle, the inflammatory cycle of prostaglandins and other immune cells in the area, and estrogen feeding that, the progesterone resistance enhancing other inflammatory factors, genetic links to other inflammatory conditions, autoimmune conditions, and other links continue to remain, such as the environmental factors, the gut and microbiome health. So now I'll turn to talking briefly about extrapelvic endometriosis. I dedicate a whole module in Endometriosis Essentials to this, so that those with this presentation have somewhere to start. And as we've mentioned a couple times now, endometriosis can affect the body well beyond the pelvis, and it can be found in other areas. And it's also been found in people who don't have uteruses because they were removed. It's been found in menopausal people. It's been found in people who have never menstruated yet because they're too young. And endometriosis is just not simply bad periods. It's not a condition confined to infertility or even the reproductive organs. It causes localized dysfunction in the tissues and organs where those lesions are present, and that can also disrupt broader systemic body processes. And up to 44% of people with lesions have uh, some that affect more than one non-reproductive body system. Out of the 200 million people potentially living with endometriosis, upwards of 88 million of them could have extrapelvic forms. It presents in non-gynecological ways. There are cyclical or chronic symptoms, chest pain, shoulder pain, GI distress, urinary issues. It's often misdiagnosed or overlooked because these symptoms are outside of the reproductive system. And sometimes it's attributed to other things, such as, oh, you have irritable bowel syndrome or you have sciatica, without looking at the why behind those things. The diagnosis typically requires advanced imaging, laparoscopy, or pathology, and treatment may involve excision surgery or multidisciplinary care in the best case scenario. Now to talk briefly about diagnostics and treatments. So the medical literature accepted subtypes of endometriosis. They categorize them based on location and the depth of the tissue infiltration of the lesion. So the first one's called superficial peritoneal endometriosis, SPE, which is most common and affecting the peritoneum. That's just the lining of your pelvic cavity. It's harder to detect via imaging. So this is really only going to be seen through the surgical means. Basically, if you get scans, it's not going to show up. Ovarian endometriomas or chocolate cysts are cystic lesions within the ovaries that are filled with dark colored blood. They're more easily detected on the ultrasound. And then the deep infiltrating endometriosis. I'm very much against this acronym, DIE, but that's what they call it. Lesions penetrate more than 5 millimeters under the peritoneal surface, can affect the bowel, bladder, uterosacral ligaments, etc., often more symptomatic and associated with pelvic organ dysfunction. And this can be detected on the ultrasound. So 2 and 3 you can find through imaging. Number 1, more difficult to find without the laparoscopy. So should these subtypes be further distinguished? In 2019, the British Journal of Obstetrics and Gynecology, one of their articles suggests that some superficial endometriosis may be a normal byproduct of menstruation, temporary deposits of endometrial-like tissue, and some superficial lesions may just not need excision if they're not causing pain to the person. The ovarian endometriomas usually occur in tandem with the deep infiltrating endometriosis. And again, the deep infiltrating is more symptomatic, more associated with the severe forms of endo. And endo suffers from this underdiagnosed / diagnosed for everything contradiction that's going on in reproductive health. So while surgery can detect deep infiltrating lesions and endometriomas, it's also the main way that the superficial lesions are found, which may not be the real cause of the person's symptoms. So if pelvic pain or fertility issues persist, it's important to rule out other causes, such as fibroids, adenomyosis, an infection, pelvic congestion syndrome, fibromyalgia, pelvic floor tension, nervous system dysfunction, other gut problems, immune problems. Unfortunately, with reproductive health conditions, they become like this blanket diagnosis that everyone can receive. So it's endometriosis is kind of used as a way to dismiss other legitimate health issues. And we need to be wary of this when we engage with the diagnostics and the medical system. So the recommended approach is to first get a specialized transvaginal ultrasound. Visible lesions usually indicate deep disease or endometriomas. If no lesions appear there, you can investigate other possible causes, pelvic physiotherapy, addressing nervous system and gut health, for example. In cases of infertility, you'd want to thoroughly evaluate the male factors as well, what's going on with the other person. And there's a poor evidence base for endo treatment. So the laparoscopic removal, either excision or ablation of the superficial endometriosis is frequently performed for those with chronic pelvic pain. However, a large, high-quality randomized clinical trial has still not been conducted to properly determine whether the surgical excision or ablation is of clinical benefit to those with chronic pelvic pain, where the only finding is the superficial peritoneal endometriosis. In 2014, a Cochrane meta-analysis found improved pain at 6 months and limited benefit at 12 months, but the findings were moderate to low certainty. And in 2020, a systematic review deemed the evidence very low quality and emphasized uncertainty regarding the benefits of surgery compared to diagnostic laparoscopy alone. And both NICE, which is one of the organizations that's creating the criteria for endometriosis, and the ESHRE, they both recommend further research into the effectiveness of laparoscopic removal for the superficial peritoneal endometriosis for pain management. So the study here is a rethink is warranted. Surgical excision and ablation of isolated SPE should not be assumed beneficial until it's supported by robust evidence. So the evidence behind these national and international endometriosis guideline recommendations are summarized in a meta-analysis that concludes that laparoscopic treatment improves condition-associated pain compared with diagnostic laparoscopy alone, but the base for this data is only 171 participants who could have had any of the 3 subtypes of endometriosis and the use of multiple treatment modalities to remove those lesions. So the data is of moderate quality. So yeah, basically we're using studies on less than 200 people to treat 200 million people. So you can see that more needs to be done here. And there's also classification systems. These are values that are assigned to the lesions to correspond to their size, how, where they're located, the depth of them. And they use things like stages 1 to stage 4. They're widely used, and many people will say like what stage they have, but this has been criticized for poor correlation with symptoms and infertility, meaning that someone could be stage 1 and in serious pain, and someone could be in stage 4 and not that much pain. But this is what the stages are. Minimal shallow lesions, and then more progressive. By stage 3, there's deeper lesions and adhesions. This is where the immune system is basically creating adhesions, and this creates a place where the organs are sticking together, and there isn't freedom of movement anymore in the pelvic area, for example, like what's shown in the graphic. There are also other classification systems, some of which were developed in Europe, and they compartmentalize the disease in a slightly different way. So the downside of these classification systems is that they don't necessarily correlate with pain severity. They're meant to categorize the progression, but in my opinion, they're more accurately a description of how long the person was dismissed or how long it took them to get treatment. And someone can have a non-infiltrative form of endo that's extremely painful, and someone can have deep infiltrating endometriosis with minimal pain. These are just overly simplistic categories. They don't account for the other organs affected, and they don't necessarily change the treatment guideline. So removing the endometriosis fully with excision surgery is considered the gold standard treatment. This is just the sooner that it's diagnosed and eradicated, the better the long-term outlook. The laparoscopic excision allows for the disease to be carefully removed from all affected areas without damaging the adjacent internal areas or removing otherwise healthy organs. And it's imperative that the surgeon have the necessary skills and knowledge of the anatomy of the pelvis or extrapelvic nerves and vessels. So ask your surgeon about their specialty knowledge of other areas: neurology, urology, gastroenterology. This is important because an incomplete operation may change the anatomical conditions. Adhesions and scar tissue can form and make further surgical intervention more difficult in the future. And even experienced surgeons who perform excision have found some reoccurrence of post-surgical endo in some patients. And so it's very important that you determine which tool and method your surgeon's going to be using and make sure that you're comfortable with that. And a trained excision surgeon is also very critical when you have other persistent bowel, bladder, or extrapelvic disease involved. Here are just some questions for your surgeon. Do you exclusively treat endometriosis? How many excision surgeries do you perform a year? Do you treat deep infiltrating endometriosis? Do you excise rather than ablate or cauterize? Do you operate as part of a multidisciplinary team? And can I see before and after surgical reports or patient outcomes? Some other tips for finding your healthcare team would be to prioritize reputation-based referrals, to get a second opinion if possible. This helps you narrow down your choices, and to join support groups to read firsthand reviews is also a good idea. Um, Making hard decisions about your treatment preferences under real life conditions is, of course, very difficult. There's out of network private pay, which obviously requires a larger budget, how far you're willing to travel for treatment, the quality of care closer to your home, being prepared to walk away if a surgeon is trying to convince you of a treatment that you don't prefer. And there are also risks and effects of surgery to consider. Endometriosis surgery is not a minor procedure. It depends on where the lesions are, how many you have, and how deep they are. And because of the poor evidence base for surgical intervention, especially for the superficial peritoneal endometriosis, the risk should carefully be weighed if this is your diagnosis. Some of those risks are surgical mistakes, organ injury, incomplete or missed removal, limited benefit for reducing pain, and reoccurrence if the lesions grow back. So this isn't meant to discourage you from considering surgery. It's just to help you understand that surgery can be very effective, but it's not a perfect or permanent solution. That's why it's not considered a cure. And a little bit about why medical suppression is not recommended. So endometriosis can't be sufficiently treated through medical suppressives like hormonal suppression with contraceptives or GnRH agonists. They found that it has no effect on the adhesion of endometriotic cells and can't improve fertility. Consider switching to a different provider if you're told that medical management and diagnosis by treating it without seeing it through medical suppression would be adequate. And it's most definitely not, and the disease can even continue proliferating unchecked while that's happening. So the reason why that doesn't work is because there's a lower expression of the estrogen receptor alpha in the endometriotic tissue. And that's what's shown here, along with the CD47. And yeah, this is just interesting to note that progestins in birth control and GnRH agonists, they primarily target the estrogen receptor alpha, and so that's why it doesn't work as well here. So now we'll move on to talking about some of the holistic strategies that I lay out in the course. I have kind of a two-step strategy with the pillars of functional endo treatment. The first half is to address pathogens, reduce inflammation, lower endospecific inflammatory factors, use aromatase inhibitors, and try to lower prostaglandin E2 that's causing all that pain and inflammation. And then in the long term, you're going to want to support progesterone receptors, support your mitochondria, and support healthy estrogen metabolism. So it's kind of two different things. You're trying to change the environment through reducing certain things. If there's pathogens, we need to address them. If there's inflammation, we need to lower it. We need to lower aromatase, lower the prostaglandins. And then on the other side, it's more of a support-based recommendations where you're supporting what would be the natural functioning of your body and your menstrual cycle as well. And there's no specific nutritional requirements for endometriosis because endo is not determined by something you eat or don't eat. However, research and clinical observations have identified several nutrient deficiencies that are more prevalent. So these are areas where I would immediately start supporting them. You can, of course, get blood work done to know exactly what's going on with each of these minerals, for example. But things like vitamin D, magnesium, iron and zinc, the B vitamins, and omega-3 fatty acids are things that you would definitely want to have a food first nourishment, trying to get those minerals in, or the sun in the case of vitamin D. And then if you need additional supplementation, to also do that. And so testing and addressing nutrient deficiencies, it'll only help your treatment. Endometriosis treatment should never require restrictive eating outside of your identified allergies, for example. Instead, I take a deep nourishment approach. So, anti-inflammatory foods and intake of diverse foods and whole foods that include all your macros, fruits and vegetables, fish, fats, proteins. I like nose to tail quality meats and seafood, even dairy if it's well tolerated for you, but I recommend sheep and goat dairy. Mineral-rich foods, so an intake of plant and animal foods that contain high amounts of minerals. That would be things like organ meats, liver, other types of animal meat, dairy, butter, leafy greens, and fruits. Sometimes a low FODMAP regimen or eliminating food allergies does help with severe digestive issues if the person has mast cell issues and other unknown symptoms related to digestion. But remember that restriction of any kind should always be thoughtfully assessed. And that's not really what we reach for first with endometriosis unless it's indicated. And also sleep and stress reduction. Both of those help enforce the nutritional support. I just want to encourage everyone to keep eating enjoyable foods, because food is a very important part of life. And if you already have endometriosis, just enjoy the food. Cytokine matching with herbs is another thing that I do in my herbal practice. So in the course, I share a bit about functional testing. So on the left is some functional tests that a person could take, for example. And if they have certain elevated cytokines, they might want to work with certain herbs that modulate those cytokines, which just means that it reduces the expression of those cytokines and the symptoms that would come with them. So here's a concise list of things that are related in some way to the cytokine specific. For example, with reducing inflammation, I like the herb cat's claw, which suppresses lesion size and cellular proliferation. In a 2024 systematic review or meta-analysis, they found cat's claw can reduce IL-6 and NF-kappa beta, which shows low toxicity, and it has a rich array of anti-inflammatory phytochemicals that are probably what's responsible for that. There's also other anti-inflammatories, again, things like curcumin, vitamin D, resveratrol, omega-3s, and bioflavonoids. Again, what we're looking at here with these interventions is what are the common immune cells or cytokines that are present, and how can we modulate them with herbalism or other functional supplements. Additionally, I really like mushrooms in endometriosis support. I found that there's a good amount of research to support the immunomodulating and anti-inflammatory effects of various mushrooms. A lot of them are wood mushrooms, things like reishi or maitake, shiitake, cordyceps. That just means that they grow usually on like old growth wood. And these are great to take even if you don't have endometriosis. They're, well established in both traditional medicine and through herbal pharmacology as promoting a healthier body. And particularly what they do for immune signaling here. I have all the details in this slide, but what they do for your immune health can't be understated as both a preventative and as a treatment protocol. So highly encourage the integration of mushrooms, whether you're eating them, because you can also eat fresh shiitake and maitake, for example, or if you're making decoctions out of reishi, like making teas and things like that, or taking them as extractions like tincture. It's a really good idea. There's also a slide here on how to lower prostaglandin E2, which again, this prostaglandin stimulates that aromatase to make more estrogen and start this cycle of lesion growth. So I like things like quercetin, feverfew, white willow bark, berberine, boswellia. These are, again, all related to prostaglandin E2 and the COX-2 expression. And what that means is basically, again, just trying to lower this prostaglandin. There's also supporting healthy estrogen metabolism, which is part of a longer term health of your menstrual cycle, and your overall health really is affected by your estrogen metabolism. What that basically means is that your body makes estrogen. It uses it in many parts of your body, not just your reproductive system, but your brain and many of your sensory organs, your breasts, they are all using estrogen. So is your heart. And you're going to need estrogen for the rest of your life. It's why you actually use aromatase to make it after menopause. So there's always like a really interesting way that the body is compensating. But basically, you make estrogen, you use it in your body, and then you excrete it. You need to get rid of it, and then you'll make more of it. But in an unhealthy scenario, for some reason, that estrogen isn't exiting the body, either through issues with the liver or issues with the gut. The estrogen can be reactivated and reabsorbed, and that is associated with many chronic health issues. So supporting a healthy estrogen metabolism, which is really about the excretion of estrogen, it can overall help your menstrual cycles, and it will definitely benefit endometriosis as well to have a better balance between your estrogen and progesterone. So I like herbs for both liver health and herbs that support digestion and gut health for this. And we also want to support the progesterone receptors, because even though the lesions are resistant to progesterone, there have been studies that show a positive correlation between a healthy progesterone and the endometriosis lesion reduction. So progesterone has a lot of good jobs in your body as well. So supporting the receptors is a good idea. And we do that through Vitex, for example, is one herb that I love for this. But also DIM, which comes from cruciferous vegetables, vitamin A, resveratrol, EGCG, which comes from green tea, and curcumin, all help improve progesterone, reduce inflammation, and reduce estrogen dominance at the same time, because progesterone and estrogen are in relation to one another. So as estrogen goes down, you strengthen progesterone just by default. There's also supporting the mitochondria. They're damaged or functionally abnormal in the endometriotic and immune cells, and enhancing mitochondrial resilience is helpful here. So things like CoQ10, rhodiola, ginseng, magnesium, and schisandra are all good choices for this, which I love working with these herbs specifically. And overall, what we're doing with endometriosis treatment here, from a functional perspective, whether or not the person has surgery, is to support the overall body, right? So we're trying to normalize the immuno environment, normalize the hormonal environment, and also with charting, you can follow your menstrual cycle and understand it better with endometriosis. And that basically means we're doing anti-inflammatory support, hormone support, liver detox, gut health, immune system modulation, pelvic and lymphatic circulation, nervous system regulation, and rest and sleep. These are the pillars of supporting your overall terrain with an endometriosis diagnosis. And so I go over all of this in further detail in the course. It kind of starts out with the intro stuff, a lot of things similar to what you saw here. And then we go deeper into the roots of endo and the extrapelvic forms. We talk in greater detail about the diagnosis and engaging in medical treatment. I go through all of the medical treatments available and why they're recommended or not. And then we talk about more of the functional approaches to healing. And I think the most important thing for me with this course was developing a long-term or post-operative preventative strategy, because unfortunately, the many years I've worked with people with endo, I have found that they do have issues after surgery, and they do need more support after surgery as well. So I wanted to make sure that everything here was more about the overall terrain and environment of the person's body that is allowing for the endometriosis to take hold, and that's why we see the reoccurrence. So if we really work on these axes of the deeper roots of this condition, hopefully, even if the person does get surgery, that they have other supports coming out of surgery. So that's another big part of the course as well. And then at the end, I talk more about hormonal health and also fertility if the person is trying to get pregnant with endometriosis. And lastly, there's a whole section on charting with endometriosis. So this isn't talked about a lot in endo care because one of the first lines of treatment is to just shut down the menstrual cycle because, you know, the main line that you're told is that estrogen causes endometriosis. So just get rid of the menstrual cycle and then you won't have pain. So charting, this totally flips this idea that it's just not useful information to have a cycle. Um, and so I talked a lot about what that might look like, how the charts might be different from your average, and also how it can benefit you to understand if you're ovulating and other aspects that are important to endometriosis care there. So I hope you will check out the course if you enjoyed this presentation. And thank you so much for your time. You can connect with me here on learnbodyliteracy.com or through my socials. I'm just going to check. I think I see there was. Yes, actually, in the course, I do have some slides on acupuncture and traditional Chinese medicine in the, I believe it's in functional approaches to healing. So that's the fifth installment or fifth module. I do have a whole section on how traditional Chinese medicine looks at endo, which is really interesting, their perspective, and also looks at their formulas that they have specifically for endo. I didn't have a chance to cover it in today's session, but it is in there in the course, yes. Does anyone have any other questions before we break here? I did want to give the floor to you. Thank you again for coming to this event. Okay, Abigail asked, do you find there are certain markers on charts outside of menstruation specifically that helps with diagnosis? Yes. So on charts, some of the things that we see are, well, first, if endometriosis is affecting their ovulatory cycle, that is very obvious. We will see whether or not they're ovulating. So is their body able to go through the normal process, or is that physically being disrupted by the endometriosis? Especially if the person has endometriomas on the ovary itself, you're more likely to see hormonal disruption in the menstrual chart from that. There's also charting bleeding patterns. We see a lot of bleeding outside of the menses, which again just mute this. Outside of the menstrual cycle, you might just be told by your doctor that, oh, it's just a shorter cycle, or, oh, this is just some ovulatory spotting or something to that effect. But we can actually see when there's inflammation and pain that's actually causing bleeding outside of the normal menstrual cycle as well. There's also, if there's a occurrence of Hashimoto's thyroiditis, we can often identify thyroid conditions through the menstrual charts by looking at the waking body temperature. We won't be able to tell if that thyroid issue or metabolic issue is autoimmune without testing for the antibodies, but we can see when the thyroid is not functioning as well, and the person's mean body temperature is going to be lower. So that's another thing that's pretty easy to identify in the chart. As well as other types of pain triggers and custom categories, I think are really useful for endometriosis as well. And yes, there will be a recording. I'm going to upload this hopefully to YouTube. So I will try to send you all a link to it so you can watch it back later and hopefully enjoy some of the slides. They are a bit dense, so I moved through them fairly quickly, but there's a lot of info on them. Yes, I have the chart diagnosis module in the course. It's the final module, and I think I spend maybe 45 minutes to an hour on the charting with endometriosis and how it can be helpful. But yeah, thank you so much for coming, and I really appreciate all of your time and energy towards this subject. It is really quite an interesting condition, and I hope you learned something. And check back on my socials. I'll be talking more about endometriosis there regularly so that we can promote this information and hopefully share it with more people. So thank you all, and I hope you have a great evening.